Welcome everybody to our second time with Dr. Nicole Plenty at the IIH Hub Practitioner Series. I'll introduce Dr. Plenty in just one second, but first I would like to introduce our moderator, Dr. Pierre Goban, who is the CEO of Serenity Medical, which is actually the sponsor of this series. So Dr. Goban is an internationally recognized expert in the field of interventional neuroradiology with more than 20 years of experience in the treatment of vascular diseases of the brain, head, neck, and spine. He's a pioneer in endovascular treatment of cerebral aneurysms, has also developed and established minimally invasive surgical approaches to treat acute strokes. Dr. Goban completed his medical degree, internship, and radiology residence at the University of Paris in France in the 1980s and has been in the United States for some time. He currently is a professor since 2001 of radiology and neurosurgery and neurology at the Weill Cornell Medical College and director of interventional neuroradiology at New York Presbyterian Hospital, Weill Cornell Medical Center in New York. He's the author of more than 100 articles and reviews pertaining to interventional radiology. We're very happy to have him as moderator. And let me now introduce our speaker, Dr. Nicole Plenty. Dr. Plenty is a double board certified OBGYN and maternal-fetal medicine specialist. She's a public speaker as well and patient advocate. Dr. Plenty attended Xavier University of Louisiana, where she held the title of Miss Xavier University and graduated with a Bachelor of Science in biology with honors. She then obtained a dual medical doctorate degree in MD and Master of Public Health MPH with a concentration in health system management from Tulane. Dr. Plenty completed her OBGYN residency training as well as maternal-fetal medicine fellowship at the University of Mississippi Medical Center, where she also earned a Master of Science degree. After experiencing a difficult pregnancy herself, to increase her advocacy efforts, she launched Pregnancy Pearls with Dr. Plenty, a vlog and podcast she created to help patients advocate for themselves by providing pre- and post-conception advice and education regarding complications of pregnancy. She has received local, state, and national honors for her involvement in health policy, mentorship, and her work in health advocacy. Among those, she's received top 40 under 40 recognitions from the National Minority Quality Forum, the National Medical Association, the Indianapolis Business Journal, as well as her alma mater, Xavier University. She currently serves on the American College of Obstetricians and Gynecologists National Board of Directors and is the new MFM, or Maternal-Fetal Medicine, Division Director for WellStar Health System. Thank you so much, Dr. Plenty. We are, again, thrilled to have you.
Thank you guys so much for allowing me to be here today. And it's always good to be back, and especially with Dr. Goban. I mean, this man is amazing, right? So he has so many accolades, especially to the field of the brain and everything related to the brain. So I'm just very honored to share this virtual space with him and with all of you guys. I know that when Edith reached out to me to ask me to talk, initially we were going to talk about like hormones and how hormones affect idiopathic intracranial hypertension. But then the last time I spoke, I felt like we didn't get enough time to talk, right? So I felt like we didn't have enough time to actually people to ask the questions that they wanted answered. And I wanted this to be more of a Q&A and a safe space for people to be able to get their questions in, for us to have a discussion about what's best practices or the lack thereof best practices, and what is the approach to IIH in pregnancy. So to start, if you guys are on this platform, you already know that idiopathic intracranial hypertension is usually diagnosed clinically, right? So people usually present with headaches. They can also have issues with papilledema, blurry vision. Sometimes people make this after doing a lumbar puncture because of all their symptoms, and we have an opening pressure that's greater than 25 centimeters. So that's not necessarily diagnostic, right? So sometimes 25 centimeters still sort of in that gray zone of, do you really have increased intracranial pressure or do you not? So most physicians make this diagnosis based off purely symptoms, and then treat patients based off symptoms. And usually we treat patients with diuretics, and the most common diuretic that we use is acetazolamide or Diamox, in an attempt to decrease that intracranial pressure. So a lot of people that I see in pregnancy have that already have this diagnosis are already on Diamox, and people may ask, what am I going to do during the pregnancy? Am I still going to be on Diamox, or I'm going to be taken off of Diamox? And usually we continue Diamox if it's needed during the pregnancy. And people that have true symptoms, we do continue that medication during and throughout pregnancy. When we're doing the preconception planning, I always tell people it's best to plan for a pregnancy to know whether or not you're on medicines that are safe in pregnancy or not. And if you're trying to get pregnant, the best thing you can do for yourself is take yourself, talk to your obstetrician or your OB provider about all of your medications that you're trying, and whether or not they can cause some issues with infertility, or they can cause some issues with birth defects in the baby. So anything that can cause issues with birth defects in the baby, we ask you not to take. Acetazolamide tends to be relatively safe. So if you're already on it during the pregnancy, we usually continue it throughout the pregnancy. Now, people that have IIH in general can have some other associated things, right? So there's an increased association with people that have polycystic ovarian syndrome, high cholesterol, and obesity that also have IIH. And some of those reasons we don't really know. People with IIH, we know in their cerebral spinal fluid. So when you have a lumbar puncture, we test that. They have a higher amount of hormones in that actual fluid. So those androgens are increased in the CSF in patients with idiopathic intracranial hypertension. And androgens, meaning those sex hormones like testosterone, androstenedione, those can also alter cholesterol synthesis that can end up having people have issues with weight loss. Can also, cholesterol is the basically start of the sex hormone pathway. So if you have higher cholesterol, that can also alter the amount of estrogen and testosterone that's being made. So that's why people with IH can sometimes also have associated issues with having normal cycles, even if they don't have PCOS, and having trouble with ovulation. So there is sometimes an association with fertility issues in people that have IIH, and it's also compounded in people that have polycystic ovarian syndrome. So because of that, because of fertility issues that some people with IIH have, I sometimes see those patients for preconception consultations to talk about how we normalize the hormones to increase the success of a pregnancy, the medications that we need to start or stop in anticipation of a pregnancy, and how we manage that pregnancy going forward. I know that there were some questions that were sent to me in advance, and I also know that some people may have questions. This is a pretty safe space, so I want you guys to have the opportunity to ask whatever questions that you want. So I'll pause and see if anybody has any questions right now.
No questions in the chat. People have introduced themselves, and we have at least several patients present, but no questions yet.
Okay, so let me start with the questions that I know that I've been sent, because I do want to make sure that we get around to those and I'm able to answer those questions. So I will pull those up and we can go through those. So the first question that I was sent was, what are the risks of women who are over 30 and pregnant and have IIH? So to me, those are two different questions, and I'm going to answer them separately. So the risk to getting pregnant over 30 depends on how much over 30 you are, okay? So of course, the older you are, the more likely you are to have a pregnancy complication. So fertility decreases with age. So women that are over 35 can have a lower success rates for pregnancy, just in general. When you have IIH, because like I said, the hormones, if you have an increasing amount of testosterone, which is not specific to IIH, but it is commonly seen with people with IIH, sometimes you're not having regular menstrual cycles. So there's a risk of, one, you may have issues getting pregnant in general, or two, you have an increased risk of having pregnancy complications that really have nothing to do with IIH, right? So if you are over 35, there's an increased risk of having a baby with chromosomal abnormalities like Down syndrome or Turner syndrome or trisomy 18. There's also an increased risk of conditions like preeclampsia, which is when you have a high blood pressure and protein in your urine. And we look at that protein in your urine as evidence of vascular damage, underlying vascular damage. And preeclampsia can put you at risk for other things downstream. So pre means before, and eclampsia is when you have a seizure in pregnancy because of those hormones secreted from the placenta. Obviously, if you have a seizure in pregnancy, that can put the baby at risk for things like not surviving, can put the baby at risk for hemorrhages in the brain, puts the mom at risk for what's called a placental abruption, or when the placenta shears away from the inside wall of the uterus, which can cause some bleeding problems. So the older you are, the more likely you are to have a pregnancy complication. But IIH, there's not an increased risk of somebody that's 20 years old with well-controlled symptoms from idiopathic intracranial hypertension versus somebody that's 35 years old. The risk is more going to be associated with how controlled your symptoms are and the risk of age and pregnancy. I hope that answers that question.
It answers it very well. I have another question related to that, is that
Okay.
many of our IH patients are overweight. So what is the relation, I mean, in terms of risk, what is the additional risk of being overweight and pregnant?
So weight causes a lot of things. One, people with IIH, like I say, they have an increased amount of usually circulating hormones, more so androgens in the pregnancy. And so with sex hormones, I know it's like really hard to even fathom. Sex hormones have a lot to do with fat cells, okay? Sex hormones, estrogen is converted from testosterone to estrogen in fat cells. So people that have an increased amount of adiposity or fat cells, it can throw off your hormone cascade. So our hormone cascade is needed to have like an LA surge. So you need a certain amount of estrogen and you need to peak at the right times in order to have what's called a luteinizing hormone surge. That's the surge you need to trigger ovulation the next day. So if you have a higher circulating amount of androgen, it's sort of telling your body, hey, we have too much. Shut down production of these hormones. And so then you don't have an LH surge, and so you don't ovulate. So people with IIH and weight issues can have issues with infertility because they're not ovulating. Things like weight loss helps to decrease the adipose tissue, which decrease the amount of circulating hormone so that your body's hormones can sort of stop saying, stop making me, right? And then you can have the normal flow of estrogen to LH surge that then causes normal ovulation. So weight loss, even as little as 10 pounds, can trigger ovulation again. So when I have preconception consults with patients, it's not because, oh, we're trying to get you to lose weight because something's wrong with you. There's nothing wrong with you, right? I'm in the same club as the majority of my patients, meaning my BMI is over 30, okay? We are in the same group. So I always tell people like, try not to
Oh, no, I'm okay to carry it to the car. I parked close.
Uh-oh. Let's mute. Okay. I try to tell people, try not to eat your calories. Try not to drink your calories. So, doing something as simple as, you're not going to drink soft drinks, you're not going to drink, smoothies or things that are high in sugar, and just start with eating your normal diet and just changing to water. You will see weight drop from you just by making that simple change. And I also encourage my patients to move around for 15 minutes after they eat. So water, move around for 15 minutes after each meal, and you will see that you can lose 10 pounds pretty quickly by doing that if you are already in the obese category like I am. So the biggest thing with obesity is you can't get pregnant because you're not ovulating. Then we have an increased risk of gestational diabetes. Okay, gestational diabetes is caused by hormones secreted from the placenta, but we know that people that are obese have an increased risk of getting gestational diabetes and developing type 2 diabetes later on in life. So we want to help, we want to encourage weight loss prior to a pregnancy to decrease the risk of that. But let me tell you, there are a lot of very thin people that also have gestational diabetes. So we know that that's a risk factor, but even losing weight or being normal weight isn't necessarily going to completely negate that risk of having gestational diabetes. Obesity is also associated with increased risk of high blood pressure issues in pregnancy, increased risk of having to have a C-section for mode of delivery, and also an increased risk of having, if you don't have gestational diabetes, it's an increased risk of having a small baby or fetal growth restriction. And we know that small babies have an increased risk of stillbirth, and they need to be monitored very, very closely through the pregnancy. So that is why, because of those risks, if you have IIH, I usually see those patients for consultation, even if they're being managed by a midwife, even if they're being managed by a general OBGYN. And then if there's obesity compounding that, I'm also seeing them every 4 weeks to monitor the size of the baby to make sure we don't have any complications that occur downstream during the pregnancy.
GLP-1 agonist, is there any contraindication with pregnancy? Have they been proven safe?
Talking
They-
about with IIH and pregnancy?
I'm talking about a patient with IIH. Her symptoms are kind of manageable, but
Yep.
she wants to get pregnant. She
Yes.
wants to lose the 10, 20 pounds that, so she can't. And she try GLP-1 agonist?
Yes. So I always recommend weight loss prior to pregnancy if we can. GLP-1s have been honestly lifesavers for weight loss. And I definitely agree that if we can, and honestly, I've seen patients on, semaglutide, they do wonderful on this. The thing about putting people on GLP-1s is that there's not a lot of data on them in pregnancy, right? And so after they lose the weight, you do need to wait before you get pregnant. So I recommend the weight loss, especially for patients with IIH, because I know there's an association with obesity and there's also association with increased androgens. We give you the GLP-1 that helps with weight loss, that also can help with regulating your hormones as well because you've lost weight, but you do need to be off of it for 8 to 10 weeks before you get pregnant. So I always tell people, gradually step yourself down if you're on one of these medicines. And usually you're doing, a weekly injection, right? I always tell people, like, do your weekly injection and then space to every other week. Like, once you hit what your goal is, space to every other week. And then you do it a half of the dose every other week. And then the third of the dose every other week. And then you stop. And then you wait a month. And then the second month, once you ovulate, then you can get pregnant, right? So it sounds like, oh my goodness, I have to wait 8 to 10 weeks. I'm like, it's really 1 week, 1 month, and then it's going to take you another month to have another cycle. And then 2 weeks later, it'll be the first time you have a positive pregnancy test. So realistically, if you just wait and not try to be pregnant after that first month of you discontinuing, the second month is going to be when you get pregnant. You go from there. Now, what I do realize that some people that are on these medications, they've adjusted their eating habits, right? And so especially if you're on these medications and you don't give yourself the time to get off of it, I see an increased risk of people that just don't want to eat, right? They have a decreased appetite, and that can put you at risk for poor nutrition in pregnancy, which can put your baby at risk for being smaller. And like I said before, small babies have an increased risk of growth restriction and demise and not making it. So we want to make sure that people are conscious of eating 3 well-balanced meals and snacks between their meals, in order to make sure you have adequate nutrition. And it doesn't have to be big meals. People are like, oh my God, I can't eat that much. I'm like, a couple bites here and a couple bites there. It don't have to be huge, but just making sure you're putting something in your mouth, usually around every 3 hours, to make sure nutritionally you are eating enough to sustain a pregnancy. But yes, I do recommend GLP-1s and weight loss prior to pregnancy.
But not during.
No, not during. Once you get pregnant, we take you off of them. And once you're done with the pregnancy, then you can go back on. The caveat is there's not a lot of studies about GLP-1s and breastfeeding. So then we have to be careful with that. Some people are in the thought of, hey, once your breast milk supply comes in adequately enough, then you can start back on them. There's not enough data for me to support that. So I always tell people, do your breastfeeding first, and then when you're done with your breastfeeding, then you can go back on your GLP-1s. But because breastfeeding, honestly, you're supposed to eat more breastfeeding than when you're pregnant.
Yeah.
You really do have to get more calories in to breastfeed, and people naturally lose that pregnancy weight just because breast milk is so high and have a high content of fat. So you're going to drop weight just by breastfeeding. So usually I don't have an issue with weight gain afterwards if people are breastfeeding, which is another reason why you may not need to be restarted on the GLP-1, because that's going to just decrease your appetite and cause you to have a low breast milk supply, which is going to, it's a full-time job to pump and breastfeed, let me tell you. So you don't want to have that issue, because you're just not eating, right? It's like you're losing weight, but your baby's not getting any food.
Yeah, yeah.
Go ahead and breastfeed and then get back
Yeah.
on it later on.
So there is an interesting question, a technical question that I can answer first. Do the GLP-1 lower ICP? And the answer is that yes, there has been a trial done, especially for this purpose. And after an injection of a GLP-1 agonist, the ICP lowers from a few centimeter water. It's really minimal, but I mean 4 or 5, I think. And this effect persists out to 12 weeks. So the GLP-1 has a small but real effect in decreasing ICP. Yes.
Couldn't have said it better.
So here we have a patient from Tennessee who asked the question, are there any concern with fertility hormones for egg freezing or IVF when you have IIH?
So usually people with IIH, their hormone levels are going to be checked prior to you going through the egg retrieval process. So then the amount of hormones that you get are adjusted based on what your hormone levels are. So yes, there is a concern about your hormones, because if you have like a raging amount of testosterone, then that tells the REI specialist how to adjust their regimen based on your hormone levels. So anybody that's getting seeing a reproductive endocrinologist or infertility specialist, they're going to get the estradiol level, testosterone level, and those specific types of estradiol and testosterones checked. Androstenedione, DHEA, DHEAS, they're going to get those hormones checked. And because some people with IIH have a higher androgen level, that then tells your REI like, hey, we need to put this person on something that decreases the testosterone level, or this person has a low progesterone level, so we need to add back more progesterone. So it really depends on what your hormones are doing. But yes, those are things that are checked. And anybody that has infertility, so if you're under age 35 and you've been trying to get pregnant for at least a year, then that's considered infertile, like you have infertility issues, and that would tell your OBGYN, your general OBGYN, to check your hormone levels. If your hormone levels are off, then that tells us, hey, we need to do hormone therapy there to try to see if we can normalize her hormones. If you're over 35 and it's been over 6 months with you not getting pregnant and you've been actively trying, then you're automatically referred to a reproductive endocrinologist, who will also check your hormone levels and then try to treat and do hormone therapy. And then if the hormone therapy doesn't work and you can't get pregnant just by adjusting the hormones, then they will talk to you about either IUI, which is in utero insemination, or IVF, which is in vitro fertilization, as two alternative pregnancy options. So yes, your hormones matter, okay? Hormones matter. And hormone therapy is real tricky, right? Because different people, we may look at someone and say, these hormones are abnormal, and they still get pregnant on them, right? And there's some people's hormones that we look at and we're like, well, your progesterone's normal. And then we have to give them more progesterone for them to get pregnant. So there's not really like this is the end all be all for every single person. So we have to individualize patients, but we do treat them based on the normal range that the labs give us to do hormone therapy and hormone treatment to try to get people's ovulation to be normalized.
I have another question that's coming from me as a treating interventional neuroradiologist. Following stenting of venous sinus for patients with IIH and severe symptoms, we see a fair number of ladies becoming pregnant after. And then we have the problem is that after stenting, we like to have 3 months of double antiplatelet therapy, followed by 9 months on only aspirin. And could you comment on that, on
Yes.
pregnancy and the use of antiplatelets, and how much is safe, and etc.
So usually when we have people that have shunt placement in pregnancy, you're right. All of a sudden they get pregnant and we're trying to leave the shunt alone when we're doing their C-section, right? We're like, don't touch the shunt. And some people have to have shunt revisions during the pregnancy as well. So, now you're decreasing the intracranial pressure. You have less pressure on your pituitary and hypothalamus. And lo and behold, people start to ovulate more, right? And they get pregnant. People that have shunts and they're still on, and they're like within
So
that.
my question was about stent, venous stent, and antiplatelets. Not
So people,
not shunt, stents.
not a shunt.
Yes, a stent. A stent
Okay.
into the venous sinuses. So
Yes,
because the
venous
stent is
sinus.
there, you need to give antiplatelets.
Yes.
Which antiplatelet is safe during pregnancy?
So we don't have a lot of antiplatelets that are safe in pregnancy.
Huh.
So most of the time we put people on anticoagulation. Usually we're putting them on therapeutic Lovenox or heparin. If there's someone that's on like a Plavix, we will continue them on Plavix, usually if it's after the first trimester. If we're talking about other anticoagulations like Coumadin, warfarin, we don't like those. We stop those and switch them to heparin or Lovenox. We don't like Eliquis. We don't like Arixtra. Those are not well studied in pregnancy. And there have been some case reports that show that these medicines can cause cross the placenta, and there have been cases of intracranial hemorrhage in the fetus. So that's really why we don't like it. And they have much longer half-lives than our shorter half-life Lovenox and heparin. So in pregnancy, our preference is Lovenox, heparin. People that have to be on Plavix, we continue it outside of the first trimester. We stop all of our longer acting Arixtra, Eliquis, our newer antiplatelets, because of their long half-life and those few case reports of intracranial hemorrhage in the fetus.
And aspirin, is it safe during pregnancy? Yes. Aspirin?
Low dose aspirin. So we love low dose aspirin for preeclampsia risk reduction. So we usually do 2 low dose aspirins a day, or up to 2. Some people do 1, 81 milligrams. Some people do 2. especially if you have a history of preeclampsia. So 162 milligrams. What we don't want to do is like 325 or above headache range aspirin. That's not safe. That's associated with, premature closure of the fetal ductus arteriosus, as well as low fluid or what's called oligohydramnios in pregnancy, as well as kidney issues with the baby. So we can't do the high dose, but the low dose aspirin, which is what most of our patients that have heart conditions are on, we do continue those and we recommend those for sure.
Good.
Any other questions?
Yeah, we have a bizarre question. That is not really your field. It's a physician who said that she's treating many IH patients with Diamox, and then they experience weight loss while on Diamox. So because of that, I think at least in some patients of IH, being overweight is secondary to IH and not a cause. So I will disagree with his statement, because in my opinion, when you take Diamox, it changes your taste. It gives you a bad mouth a bad taste in your mouth, and you don't like to eat as much. And I think that Diamox, you decrease your eating, but it's kind of an interesting concept. What is the relationship between being overweight and IH? Is it only a one-sided relationship, or does IH itself increase weight? I don't know.
I don't know the answer to that. It's sort of like which comes first, the chicken or the egg. I don't know, and I don't think anybody really knows. We know that IIH is associated with increased circulating hormones that can cause weight loss. I mean, weight gain.
Uh-huh.
But, whether there's causation, I'm not really clear on that. And then in terms of Diamox with weight decreasing weight in patients, I'm not really sure, because Diamox is a diuretic, right? So some of that could be water weight that people are losing, but there's not a specific like, hey, this is what's going to be advertised for actual weight loss. I always encourage people to change their diet as well as exercise for weight loss. And if we need to put somebody on a supplement, then we talk about what we need to put them on for weight loss, but not use Diamox specifically for weight loss purposes.
Okay.
And who knows, some people may take Diamox, their symptoms get better, and they do want to be more active. Like that is, could explain why there are patients that lose weight. I mean, if you have a headache all the time and blurry vision, you're not really motivated to get out of bed much. But if your symptoms are treated and your symptoms are controlled, then, you are probably more active. But Diamox specifically isn't specific for weight loss.
So I have a very interesting question from the audience. It's not directly medical in the sense it's technical, but as a physician. A patient was recommended Ozempic. She's 5 foot and 180 pounds, 28-year-old, and she has a high opening pressure on her lumbar puncture. So she's overweight. She has IH. She's recommended Ozempic, and the insurance company doesn't accept because because she doesn't have diabetes, because she doesn't have a typical indication of Ozempic, and Ozempic expensive, etc. So I know you are treating many patients. How do you help patients getting reimbursed, getting insurance approved for Ozempic?
So Ozempic is very tricky, right? Because they've definitely advertised Ozempic specifically for people that are diabetic, right? Semaglutide is the arm that's pretty much the generic that is advertised for weight loss. So semaglutide or Wegovy is the weight loss arm, and Ozempic is for diabetes, but they're the exact same drug. And so what I usually do to try to get my preconception consults approved. One, I draw A1C to see if they're in the pre-diabetic range. And if they're in the pre-diabetic range, then we ask for a physician-to-physician consult through their insurance for there to be a prior authorization and approval. Like that is how I have personally handled it. Usually if I ask for physician-to-physician consults, then I honestly, I've never not been approved. Because usually if you talk to
You're
another,
good.
it takes some time, right? Because you have to block
Yeah,
your schedule and you have to actually
take some
have a
energy.
conversation to say, hey, this is what's what we're trying to do. And this is actually, this weight loss is going to help. And if they're in a pre-diabetic range, then it's going to be covered. Like you don't even have to do that. But physicians need to know, they need to check to see if that hemoglobin A1C is somewhere between 6 and 6.5, then technically speaking, you're pre-diabetic. I know that's not anything that you should be happy about. For an insurance company, you can justify that this is the pre-diabetic range and we're doing this for preventative purposes.
Especially a 28-year-old.
Yes. The deal with people that, because 180 is not that overweight for an insurance company. So you really do have to figure out if they're in this pre-diabetic range to get it approved, right? Or if you need it to try to help regulate ovulation. But if you do that, you have to prove that they failed some things. So it's a matter of documenting, like, have you tried OCPs? Which one have you tried? Have we tried to lose weight on our own? Did that help with ovulation? So it's a matter of making sure you're documenting that there's trial and error that has happened. And then if there's anything that has like pre-diabetic symptoms, then you're more likely to get that approved. But you almost have to do a peer review, like a physician to physician peer review to try to get that approved. Now there also, I mean, there are people that their insurance won't cover it even if they are approved. Like there's some insurance companies just don't approve these newer drugs because they're and then you have to encourage your patients to go to specific clinics, right? There are nutrition clinics that have Wegovy at a much cheaper rate than you would getting it prescribed. If you're prescribed and it's not insured, I mean, it could cost somewhere like $900 a month. It's very expensive to get it done. But some of these weight loss clinics, you can get, encourage them to go there, whereas it's more like $150, $200 a month, which is much more affordable for patients. But yeah, it's the dance that we do to get things approved via insurance can sometimes be very complicated. And it really depends on what the insurance company is, which insurance company is, and if it's something that can be covered, even if you did have overt diabetes, because some insurance companies do not cover all diabetic meds.
So we have another question. It's actually several questions. Is that
Okay.
it's a patient with IIH and she's worried that a pregnancy can increase the risk of stroke. So my answer will be no. IIH and stroke, no. She has 3 stents in the venous sinus. That's many. So yes, she could be more hypercoagulable during pregnancy. It's known that during pregnancy you can be a little more hypercoagulable. So she could resume the aspirin probably. And another question.
Depending on how far out she is, she may need to be on anticoagulation, or aspirin for sure. Yes.
And so she's asking also a more generic question. Does pregnancy in general increase the symptoms of IH, and does it increase ICP?
So usually not, right? So usually people that have symptoms before pregnancy usually have symptoms throughout their whole pregnancy. People that tend to be asymptomatic during pregnancy tend to continue to be asymptomatic. If they were asymptomatic before, they tend to be asymptomatic throughout the pregnancy. But there are people that do get symptoms, and we are starting them on some type of diuretic, which is usually Diamox, during the pregnancy to treat their symptoms. But usually people have pretty safe pregnancies, even with IIH. It's a matter of getting pregnant. That's the biggest barrier I've seen with IIH and fertility because of those hormones. But once you get pregnant, for the most part, people tend to have pretty safe pregnancies.
But it's true that the symptoms of IIH are more difficult to treat during pregnancy. For example, if you have severe headaches due to your IIH and you become pregnant, there are many headaches medications that are
Yeah,
forbidden.
you just can't take. Yeah, it is more difficult to treat because some people, one, some physicians are not clear about what IIH is. Let's start there. And then two, some people are not don't want to give people medicines for headaches, right? So there are medicines that we give people for migraines that we can give people for symptomatic relief in addition to diuretics. So a lot of people don't like to give people pain medicine in pregnancy. So that's not just specific to IIH. That's anybody that has any type of headache or any type of pain syndrome in pregnancy. It is more difficult to treat during pregnancy just because people don't want to give you pain medicine during the pregnancy, but it's not just because of IIH. And so if you have a physician that doesn't feel comfortable treating, your symptoms, then you need to ask like, hey, is this because I have IIH? Is it just because you don't like to give certain pain medicines? And can I be sent to a specialist that may be more familiar with treating, symptoms of IIH? So you'll be seeing a neurologist, and most of my patients do see a neurologist in addition to seeing myself, so that we can touch and agree and decide on what medications are the safest for patients during the pregnancy. And there are patients that have issues with headaches that have tried several things. And so we know what works and what doesn't work. And if there's something that you're on that does work and it's not safe in the pregnancy, then we have to figure out an alternative, as opposed to like starting from scratch. Like, okay, well, let's try Tylenol. Now let's try Percocet. Well, if you've tried those already, we know they don't work, then we need to go to the next thing. So yes, Dr. Gobin is right. It is more difficult to treat it if you have symptoms during the pregnancy, just because people are afraid to treat you, unfortunately.
So we have another question. That's something that you have addressed before. Just summarize your 12 years of training in 5 minutes. Besides weight loss, is there any way to regulate those hormones to increase fertility?
So, one, I always tell people to keep up with your menstrual cycles, right? If you are, and I always encourage people to get an app, literally record the first day of your last menstrual period and any bleeding you've had between there. So we need to know if you have instrumental bleeding or if you're having normal monthly cycles. Usually, if you're having normal monthly cycles, meaning your cycle starts every 21 to 31 days, okay? Once we go over 32 days, that to us is considered anovulatory bleeding. So we need to have a cycle every month. So, and it shouldn't be more frequent than every 3 weeks. So if you're having that, to us, that means those are signs that your menstrual cycles are regular and your hormones are regular enough for you to have normal fertility. Okay. If you're not having normal menstrual cycles, you can't assume that you're going to get pregnant because you're having intercourse. Like the cycles have to be regular. That tells us that the hormones are also regular. If they're not regular, getting a preconception visit so your hormone levels can be checked, it's what's needed. Some people need to be on different hormones, different hormone therapies, need hormones added back, or may need to be on some type of birth control to suppress ovulation and then withdraw it to cause a withdrawal bleed that can then trigger normal cycles. So it really depends on what's going on with your cycles, but your clue is that you have normal monthly menstrual cycles. And if you're not, get that preconception consult so they can go through your hormones with you. The other thing is weight loss is the number one thing that increases fertility, hands down. It's the number one thing. Three, if you're someone that is going to get a shunt, just got a shunt, um, or um, or someone that is on anticoagulation, then you need to wait to get pregnant, right? Because your neurologist is not going to feel comfortable doing procedures on you if you are trying to get pregnant actively, okay? That puts you at risk for a lot of things. Like they're like, oh my goodness, you're 4 weeks pregnant now. We just, did this procedure and now we have you on, we have you on anticoagulation. Like we don't want to confuse that. We want all your treatment to be done if you're going to have a procedure before you get pregnant so that you won't be someone that needs a procedure done in the middle of your pregnancy. Procedures during a pregnancy, meaning you're having to be put under anesthesia, can increase your risk of miscarriage, specifically if they need to be done in the first trimester. So I would encourage you to get any procedures or do any experimental treatments that your neurologist is putting you on before you get pregnant, making sure that experimental treatment is complete. If you need to lose weight, try to lose your weight before you get pregnant. I'm not saying you need to get down to a BMI of 25, but as little as 10 pounds of weight loss will help with your ovulation and your cycles. If you are extremely obese and need to be on, Wegovy, semaglutide, or one of the other weight loss medicines, do that, but don't try to get pregnant while you're on those weight loss medicines. Lose your weight first, and then after you've gotten to your ideal weight or the weight that your goal weight, then get off of that medicine. And that can be 1 month or 2 months, depending on which medicine that you're taking. And then after you get off of those medicines, then you try to get pregnant, or then you go through your preconception process there. But those are the things that I usually recommend. And if you have other associated medical conditions, right? So there is an association with people that have type 2 diabetes. So if you have other conditions, make sure those other conditions are controlled before you get pregnant.
So we know that IH strikes mostly young women, but we see also postmenopausal or during menopause women with IH now.
Yeah.
And so the question is that, it's Margie who is asking the question. Please address the problem of IH along with being postmenopausal. What is the hormonal relationship? And also, the weight gain that many people have during the menopause.
So I have less experience with postmenopausal IIH, right? Because I take care of high-risk pregnancies. But as you age, your estrogen level decreases, your androgen level increases. So you have a higher level of testosterone. So theoretically, I can see how you have women that have more symptoms of IIH as you age, because then you have a higher circulating androgen level. Those circulating androgen levels cause you have difficulty with weight loss. So then you have an increased risk of obesity once you age, and you still have symptoms associated with IIH. So all these hormones go hand in hand, but your hormone level as you age is going to decrease until you are postmenopausal. And then your estrogen level definitely decreases even more. And some people need the estrogen supplementation to control those symptoms, because you have symptoms of IIH, which, usually people have issues with vision, papilledema, issues with headaches. And then you also have issues with lack of hormone control because of aging. So you have hot flashes, trouble sleeping, also headaches. So some of these symptoms can definitely overlap. So if you have IIH and you also have symptoms of menopause, it's going to be crucial that you're followed and those hormone levels are followed, and you get hormone therapy for management of your menopausal symptoms. And then your neurologist is going to continue to follow you for your symptoms of IIH and making sure you're up to date on all of your screenings and things like that.
So IH during menopause could be an additional indication of estrogen replacement.
Yes. Anybody else?
We don't have any other questions from the audience at this
No?
point. No.
Okay. Let me go back to our little handy dandy cheat sheet to make sure we've answered all the questions there. Someone asked about Diamox during the IVF process specifically. So, I will say this one is a little bit more controversial. So if you're pregnant already, we can start Diamox. During the IVH process, usually they don't want you to be on an actual diuretic during that process, right? Because that diuretic can cause you to be dehydrated, which can also decrease the amount of mucus secretion that that your body is making. So usually your REI specialists are going to tell you they don't want you on Diamox, but I have had a couple patients that couldn't really function without it. And so they were on it at the time of their IVF. So that has to be individualized. But in general, most REI specialists will take you off of Diamox for your egg retrieval and then put you back on it. And then once you're ready for your transfer, take you off of it again for your transfer. And then once you have a confirmed pregnancy, can put you back on it. But because, you know, there's a lot to do with like making sure that the mucous membranes aren't dry is why they usually don't want you on Diamox during, specifically during IVF, the IVF process. Okay, I think that that's all the questions. So I just want to encourage you guys, like if you are trying to get pregnant or you have, you know, if you're a provider and you have patients that are trying to get pregnant, I would just encourage you to encourage them to make sure they're having regular follow-up with their primary care provider and the neurologist. You don't ever want, and this is not just with IIH, it's with any condition. If you're being treated by a specialist, you want to make sure that specialist knows you're trying to get pregnant so that you're on pregnancy safe medicines and that your symptoms or your comorbidity is controlled before you get pregnant. What we don't want to do is put you at risk of losing a pregnancy just because, or you suffering or being miserable during pregnancy just because we, you know, there are medicines that we can't put you on or we haven't controlled you prior to the pregnancy. But most patients with IIH actually get through the pregnancy pretty safely. Okay, they're pretty safe pregnancies. They just need to be monitored a little bit closer to make sure we don't have those increased risk of, you know, gestational diabetes, preeclampsia, and growth restricted babies. So you're just monitored by a maternal-fetal medicine specialist, your neurologist, and your OBGYN during the course of your pregnancy.
So to summarize, if you have IIH and you want to get pregnant, try to lose at least 10 pounds before, and it will improve both your symptoms of IIH and your facility and your ovulation. You can use GLP-1 during this phase, but you should not use GLP-1 during pregnancy or during breastfeeding. Diamox is safe during pregnancy. Aspirin, is it safe during the 3 trimesters of pregnancy? Is it safe all during
the whole pregnancy?
Okay, so aspirin is safe.
Right. The only time we hold the aspirin, sometimes anesthesia doesn't like the aspirin for the epidural, right? So they ask us, so we usually hold aspirin the week before the anticipated delivery. And if it's somebody that we don't know when they're going to deliver because they never had a baby before, then we stop the aspirin around 37 to 38 weeks and then allow them to, you know, go into labor. Now, if it's someone that needs that aspirin for anticoagulation purposes, then we continue it.
Okay, I think everything is clear for me. Audience, if you have any questions, do not hesitate to send it now. We have a few more minutes.
Don't be strangers. Thank you, Dr. Gobin, for the discussion. I have learned a lot from you today.
Oh, the reverse is more true.
Yeah, thank you so much, both of you.
No other questions? We have a shy
No
group.
other questions.
Okay.
I think you have answered all the questions, Nicole.
Okay.
Thank you very much.
Thank you. Thank you guys for having me. I appreciate being here.
Thank you, Barack, for hosting us. And
Thank you so much. And it was great to have all the questions answered during this. It felt very integrated. So thank you so much.
Good. Good. Thank you.